I would like to talk about how to optimize the OocyteFactor in XZ cycles conducted in age-related infertility or advanced maternal age. Well, we will focus on this talk about optimizing the OocyteFactor through optimization of the ovarian stimulation, optimization of the final maturation and ovulation triggering, and optimization of oocyte retrieval. We all know that there is association between lower cumulative live birth rate and advanced maternal age, and this decline is independent. It's not related only to the poor ovarian reserve. The age-related decline in cumulative live birth rate is actually not a function of uterine aging, not a function of the tubal aging, it is a function of the oocyte aging. How important is the OocyteFactor? The ASHRI guidelines regarding the ovarian stimulation ranks the three most critical steps in the IVF cycle. Number one, the in vitro gamete handling. Number two, the embryo transfer. Number three, the ovarian stimulation. So the quality of ovarian stimulation is one of the cornerstones in conducting the IVF cycle. In a randomized controlled trial conducted and published in 2014, they showed that retrieval of one more oocyte in poor responder would increase the live birth rate by 5%. How would a clinician judges his performance regarding the oocyte quality? We have the FORT, the FOI, and the maturation index. The FORT is the proportion of the follicles to the intrafollicular count. The FOI is a proportion of the retrieved oocytes to the intrafollicular count, and the maturation index, the proportion of the M2 oocytes to the retrieved oocytes. The FORT reflects, if the FORT is substandard, it reflects some sort of substandard stimulation. The FOI reflects the stimulation, the triggering, and the oocyte retrieval, and the maturation index may reflect stimulation and final triggering defects. So what is the difference? What is different in aged women? We have diminished ovarian reserve, we have high basal and even premenstrual serum FSH level, we have accelerated follicular growth, tendency to premature ovulation and luteinization, and increased risk of oocyte aneuploidy. To start with optimizing ovarian stimulation, we have three strategies. Number one, pinpointing the favorable months. Number two, the ovarian stimulation protocol and the dose, and number three, the adjuvant treatment to ovarian stimulation. The concept of pinpointing the favorable months, we all know that in advanced aged women, we have favorable months, the woman responds well to stimulation, and we have unfavorable or unlucky months in which the woman wouldn't respond well to stimulation. In order to pick or pinpoint these favorable months, it's recommended to do basal transvaginal ultrasound in early follicular phase on day 1 or 2 or 3, and do basal hormonal profile. We wouldn't recommend starting stimulation unless the transvaginal ultrasound shows no risk with corpus luteum, no early follicular activity, and the basal FSH below 14, the basal E2 below 50, and the basal progesterone level is below 1.5 nanogram. There is a belief that GnRH agonist protocol, the long protocol specifically, is not suitable for the advanced maternal age or the poor responders, which is not quite right. In an RCT published in 2014, they compared the long agonist with the short agonist to the GnRH antagonist protocol. The study was not powered to judge or compare the pregnancy rates, but we see that the cycles reaching embryo transfer were significantly higher in the long agonist protocol. The authors of this RCT concluded actually that long GnRH agonist protocol offers a suitable choice for poor responders, and this article was cited in the ovarian stimulation textbook edited by Professor Abulghar and Professor Rizq, and the authors of the chapter literally states that long-chain rich agonist protocol should be the first line treatment for expected poor responders. In a meta-analysis of 26 trials in the general IVF population, the pregnancy rates are higher with long-chain rich agonist protocol. In the subgroup analysis of this meta-analysis of 6 trials for the poor responding patients, there was no significant difference in the ongoing pregnancy rate between the agonist and antagonist protocols. And in a study comparing the efficacy of the agonist stop and the antagonist and the ultra-short protocols in women above 40 years, the pregnancy per retrieval was highest in the agonist stop protocol. To analyze what is the benefit of the agonist in the advanced maternal age, we see that follicular asynchrony, early rise in serum progesterone, tendency to premature ovulation are the problems in the advanced maternal age, which are all minimized in the agonist, whether the conventional long agonist or the GnRH agonist stop protocol. These risks are high in the GnRH agonists and high in the FLAIR protocol. What we practically recommend, if the patient is, the aged patient has a good ovarian reserve, we recommend doing the GnRH agonist protocol, whether the conventional long or the stop protocol, and using the maximum dose 300 to 450 international unit per day. If the patient has a low ovarian reserve, we can either use the antagonist or the ultra-short FLAIR protocol. And if she's having an extremely low ovarian reserve, we may use the minimal stimulation protocol or the FLAIR protocol using the least dose. And we do not believe that the patients who have extremely low ovarian reserve, the intrafollicular count is 1 to 2, would benefit from increasing the dose of ovarian stimulation. What about the progesterone stimulation protocol? Professor Hisham has just talked very thoroughly about it. We have two kinds of progestin primed protocols. Either we use the endogenous progestin in the luteal phase or the double stimulation, or use exogenous progestin primed protocol. They yield higher number of oocytes per single cycle. They shorten the time to embryo pooling, but LHRH agonist triggering is a must. Elective freezing is a must. Longer time to live birth. So we wouldn't recommend this protocol unless you are intending to do embryo pooling. If you are intending to do fresh embryo transfer, it's better to use either the GnRH agonist or the antagonist protocols. Actually, embryo pooling has been studied as its efficacy in the advanced maternal age. The current literature states that embryo pooling is associated with lower cumulative lower live birth rate and longer time to live birth rate in advanced maternal age. And the PGTA per se also is not promising. The current literature states that it does not improve the live birth rate in poor responders. Embryo pooling, however, is featured by or recommended in two scenarios. Number one, if you are intending to do PGTA for an indication other than just to improve the live birth rate in advanced maternal age. And it's also helpful in counseling the patient. As we said a few minutes ago, that we have favorable months and unfavorable months in stimulation in advanced maternal age. So if you counsel the patient from the start that you may need several cycles to reach a good quality embryo, this is good with the embryo pooling strategy. As regards the adjuvant, we have three main adjuvants that are debatable: the DHEA, the CoQ10, and the growth hormone. Currently, the ESHRI guidelines does not recommend giving any of these adjuvant treatments, but actually a subsequent meta-analysis and systematic review shows some benefit from the growth hormone, CoQ10, and DHEA. and still further studies are needed. As Professor Hassan just said in his first lecture, those patients are desperate. If you are using quite non-expensive medications as a desperate solution, I would recommend to use it. Regarding the maturation and triggering, as we know, if you go for triggering at lower dimensions, you will encounter high proportion of immature oocytes. If you go at larger dimensions, you will go into post-mature oocytes, and both are bad. If the patient is average responding, the conventional recommendation is to do trigger when you have at least 3 leading follicles between 17 and 18 millimeter, and most of the recruits above 14 millimeter. But in the poor responders and advanced maternal age, it's recommended to do the trigger at quite smaller dimension at 16 millimeter to prevent or to avoid the premature luteinization and premature ovulation. This is for the extremely poor responders who have just 1, 2, or 3 follicles. Regarding the dose, the conventional dose is 10,000 international units of the urinary, or 250 of the recombinant, and 0.2 to 0.3 international units of the GnRH agonist. If the patient has unfavorable history, which is history of previous empty follicles or previous immature oocytes, either we do the dual trigger using the urinary or recombinant with GnRH agonist if the patient has not received the GnRH agonist as a short or longer protocol, or to use a higher dose HCG. Finally, we will talk about the optimization of the oocyte retrieval. We will talk about follicular flushing, time to oocyte retrieval, and interval oocyte retrieval. Flushing, the current evidence does not support routine flushing and even does not support flushing for the poor responding patients, but actually this evidence it relies on just 2 studies, and even when he compared the oocyte yield, he compared it in average responding women. As you see, the mean follicles retrieved 12, 10. This is average responding women. Actually, there is no analysis, there is no subgroup analysis on the poor responding women. So what we recommend is to do flushing for women who have less than 5 follicles, because as we said a few minutes ago, that retrieval of 1 good oocyte in advanced maternal age and poor responders would increase the live birth rate by 5%. The time to trigger, again, if we go earlier, this is the time between HCG injection and the oocyte retrieval. If we go earlier, we will encounter higher number of immature oocytes. If we go later, we will encounter the premature ovulation. What we recommend that in the antagonist and progestin prime protocols, if there is accelerated follicular growth, if we have 1 or 2 follicles or previous history of premature or pre-retrieval ovulation, we go to oocyte retrieval at 34 to 35 hours after the trigger. If we have long protocol, average stimulation, average response, and no adverse previous history, we recommend doing the oocyte retrieval between 36 and 37 hours. Sometimes in the advanced maternal age or poor responders, we find no oocytes retrieved. We start with aspiration of the first 1, 2, 3 follicles. If there is no follicles retrieved, we abort the procedure and recover the patient from anesthesia and do quantitative serum HCG assay. If it is negative or low, we re-trigger and redo the ovum pickup after 36 hours. This patient has not received the trigger for whatever reason. If it is high, we do interval of oocyte retrieval on the same day after 2 or 3 hours. They frequently retrieve oocytes. If they fail to retrieve oocytes, we re-trigger and do the ovum pickup after 24 hours. So the final take-home message, an expert clinician is essentially required to lead and individually tailor an exit cycle to aged women. Each and every attempt should be made to optimize stimulation, triggering, and retrieval of the oocytes in aged women. As for this group, each added oocyte counts. Thank you.